Good afternoon, everyone, and welcome to Debate Cameroon Perspectives. Welcome after a month or so of the air, which was forced on us due to technical constraints. However, we are back and hopefully we'll be back for a very long time. We are back to stay. Today's edition of Perspective will be in the form of a roundtable, a first of its kind, a discussion that will be centered on healthcare and primary healthcare in Cameroon. We commonly consider healthcare as access to good and affordable healthcare facilities. However, primary healthcare embraces 5 different types of care, which include promotive, preventive, curative, rehabilitative, as well as supportive and palliative care. The basic principles of primary healthcare include accessibility to healthcare, public participation, healthcare promotion, use of the appropriate technology in the technology era, as well as intersectoral cooperation. The problems in the current healthcare system in Cameroon are known to everyone. Accessibility, availability, and affordability are amongst the top priorities and needs immediate intervention. In the last few years, the healthcare system in Cameroon has been characterized by a lot of disheartening events. Cases that come to mind include the Monique Komate scandal, a 31-year-old pregnant woman who died in the hospital facility in Douala, the economic capital of Cameroon, and was later cut open in the hospital facility by a family member in an attempt to remove her twin babies. Most recently, a 17-year-old boy who was stabbed in school was taken to the hospital. He later on died due to lack of reanimation facilities. However, photos of the kid as well as nurses were seen floating in the social media, which were exposed by the nurses. So today I have a guest list who come from diverse backgrounds, all of whom are experts in different specialties in the medical field. Today, most of them have also worked in the healthcare system in Cameroon, or at least have consulted or have been patients in the healthcare system in Cameroon. They will discuss their different experiences, the challenges they encountered or face, the healthcare policy as they know it, as well as recommendations to improve the healthcare system in Cameroon. So among my guest list, and I will introduce them one by one, here I have Dr. Arnold Onana. So Dr. Arnold is a Cameroonian-born physician. He was trained in Cameroon and has a passion of healthcare system policies and the delivery of healthcare system. He still loves to consult, so he still has a passion for clinical medicine. But however, he's looking for a way to integrate both policy and healthcare and clinical medicine. He has significant experience in HIV prevention and non-communicable diseases like diabetes mellitus, which we'll discuss a bit today. He lives a simple life, and him and myself, we argue from time to time on different topics in the social media, mostly on Facebook. He has worked in Cameroon, he worked in Bamenda, and later in Roundtable. Our next guest is Dr. Ayukekbong Jim. Jim and myself have known each other for a long time. We went to school together. He holds a Bachelor of Medical Laboratory Science, a Master's in Biomedicine, and a PhD in Molecular Epidemiology. He is certified in infection control and is a member of several international associations, as well as an author in several peer-reviewed journals. He recently served as public health officer in Health Canada, the public health agency of Canada, as well as a United States USAID PREDICT program in Central Africa, where he served as one of the directors. He's also the founder of Redeem Biomedical in Cameroon, and most recently he founded and also functions as an executive producer of Epitech Public Health in Canada. So our third guest today, and we decided to make sure we have both genders
represented.
present. And so our other guest today is Christabel Mfona. She is a doctor in pharmacy and most recently graduated from uh, a pharmacy school in Rochester, New York. She currently works as an independent pharmacy. And while she's working, she has a big passion for antibiotic and drug abuse as well as antibiotic resistance. She's also a mother of one. Our next guest who will be joining us later today is Dr. Ngwashi Christabel. And when she joins, I will introduce her. So, ladies and gentlemen, welcome and thank you for accepting our invitation to educate the public on some of the aspects of healthcare in Cameroon. So I am going to start with Dr. Arnold Onana. So you worked in Cameroon. Can you highlight us some of your experiences and the challenges you encountered in the healthcare system?
Thank you, Dr. Terence Agbo. Thank you, dear audience of the big debate. It's a real pleasure to be here today, and you have heard the introduction that our host has said about me. If I may add just a little bit on that, because it's going to maybe explain the kind of the perception of the difficulties of that system that I have been part of once and still hope to contribute in the future. So I started in the system as a student and then later on as a physician working in a rural district hospital. I worked in that kind of setting for 1 year and it allowed me to see, the kind of difficulty I saw there was the poverty of people living in those places that was a big limitation to access to healthcare. And so I saw people dying of diseases that theoretically should be very easy to manage, should be very easy to prevent, but you could see people dying of such things. So that was one of the things I noticed as a healthcare practitioner. So there was lack of knowledge. So already health education will be a big thing because people don't know a lot about their health. They don't know a lot about how to get information on what they need to know to prevent, to have access to healthcare, and then financing their their healthcare was a huge issue. It was one of the things I noticed as a healthcare practitioner under the system, directly in clinical care. Later on, when I moved to another role, which was that of a program manager, and more specifically in HIV, there were other challenges this time that I noticed. There was still the problem of funding this time of health programs in general. There was a lot of governance issues that I noticed too there. It's a big problem in Cameroon and in the health system as we see it right now. And those are one of the issues that struck me a lot. I think if we are going to have to make any kind of progress in that nation, then the issue of governance and the issue of financing or funding of our healthcare are very important pillars that we would have to tackle. Those were like the things that I noticed. There was a lot of demotivation of healthcare personnel, of healthcare workers that you would also notice that exist in the country. I mean, if those three things I've mentioned just to start with are very interwoven, it's difficult to look at one, separately from the others,
Yeah, from the other.
especially something like personnel demotivation. It's hard to look at it isolated from the other aspects or the other problems that I noticed as someone who was first of all, you know, down on the chain and then later on in a managerial position. So in a nutshell, Those are like problems that I noticed, working in the system. I know as we talk further, we're going to develop on some of these issues.
Yeah. Okay. Great. Yeah. So yeah, thank you very much, Arnold, for that introduction and answering my question. We'll have some talking points you've already raised, but before we come back to that, I'll probably let the other guests have a round on the same subject. I know Krista hasn't worked in the health system, but at least she may have been to the hospital. So, Krista, can you give me some of your experiences with the health system in Cameroon? I mean, it may not be direct experiences, it may be something you have heard or may have witnessed.
The experiences I had in Cameroon were not that bad, especially when it comes to like patient experience. Last time I went home, my son was sick, so I actually spent the night in the Limbe hospital, Bota hospital. Wasn't as bad as I thought it was going to be. I mean, there's still so much room and there's still so much to be done.
Yeah, Krista, you are breaking there. We seem to be losing you. We didn't hear your last sentence, if you are still there.
Yes, I'm still here.
Yeah, we didn't hear your last sentence. The last word we heard was Bota.
Oh, okay. Like I said, like Dr. Onana said, there's, I think most of what is lacking is basic training and access to healthcare or access to basic healthcare products. So I think that was what was most lacking during my experience, say at the hospital in Cameroon. Again, there's still hope. There's so much to be done. A lot of healthcare professionals are coming together to see what they can do, but it's not where it's supposed to be, and we still need a lot of activism, especially from us healthcare professionals, for people to actually know the consequences of what they're doing in, say, the healthcare professionals or even the patients themselves. So, like I said, there's still room to grow.
Okay. Yeah. Thank you so much. So, Jim, you and I, we probably have similar, maybe not identical experiences. So, you trained as a medical laboratory scientist. You also worked there, and recently you went back serving in a different portfolio, but it's still an aspect of public health. So, could you tell me some of your, tell the audience, not me, probably I know them, some of your experiences working in the healthcare system and some of the challenges you may have encountered or know are encountered.
Thank you very much, guys, and thanks to all the panelists. It's indeed a pleasure to be part of this discussion. I think it's my second time of joining the debate Cameroon perspective, this time around as a panelist, and I'm humbled to be sitting with one of our finest healthcare practitioners from Cameroon extraction. Well, just like the other panelists have said, we are not yet there. There are a lot of things that that could be improved. And I'd like to predicate my contribution to an area which is actually my niche. Like you rightly said, I am a medical lab scientist by training, though I have taken myself off the career, but that is my substantial to start with. And if I have to focus a little bit on that, there is a problem. As you know, the healthcare system in Cameroon has 3 levels. It has some kind of the district, or what we could call the primary level. You have some kind of provincial, and then you have the more centralized national, where they are responsible for developing health program management and strategies within the country. And if you look at, for example, the primary, when I went down some years ago, I'm going to try to cite an example of the management of diarrhea diseases in children. Diarrhea is a very, very common public health problem. And it is a priority public health concern, even for the country of Cameroon. As we know, diarrhea is a leading cause of death amongst children less than 5. But the irony in Cameroon is that the diagnosis of diarrhea is very, very limited. How limited is it? If you go to the hospital, your child has diarrhea, they'll do a microscopy. And microscopy can only identify parasites or worms or bacteria in the stool sample. That microscopy cannot identify any virus. And rotavirus, for example, is the leading cause of diarrhea in children. But you don't have any system to identify a rotavirus in the stool sample of a child. And most children who are sick of diarrhea are probably suffering from rotavirus. So as an enterovirologist myself, when I was running my organization, Epitech, Redeem Biomedica, I came down with a kit for diagnosis of diarrhea. And I did a lot of campaigns in the Northwest, in the West, Southwest, in the Littoral, and the Central region, just to raise awareness about how we can change our perspective in the management of diarrhea. But somewhere along the line, it just ended up in the shelf of the ministry, and no one was so interested in that. And when patients are sick of diarrhea, most likely the physician will provide antibiotics based on the microscopy that is limited to bacteria or parasite identification. And yet, we all know that the rotavirus is a major cause of diarrhea. Thanks be to God, there is a rotavirus vaccine that's been given out there from children within the age of 2 months, 4 months, 6 months, but there is no evidence-based management of diarrhea within the system. So that is a problem which we can, try to develop. And I'm happy if there are people in the audience who can challenge this and try to also educate us on some of the developments that have happened within this kind of area in clinical care. Yeah.
Yeah. So summarily, I could say, like for you in particular, you have a big passion for diagnosis of diseases, and like an example you cited is the case of diarrhea. And so we know, according to WHO figures, and in most developing countries, diarrhea is one of the leading causes of death in children. And if you misdiagnose the cause, if you start treating the symptoms, it's a very, very big problem. Okay, yeah, so I'll probably go back to Arnold. He mentioned some very interesting facts about, let me say, some of his interesting challenges and some of the issues he noticed. So I'll probably go, I have a few more questions to him. And lady and gentlemen, please feel free to interject each other if you have anything. If you have anything to add. Okay, so Arnold, you mentioned that there are some diseases that people die out there, or which they are not supposed to die. Can you give us some of such examples? I mean, I know some, Jim probably knows some, Crystal might know some, but could you give us some few examples of the situations or some circumstances where people die from such diseases?
Okay.
And what would be the causes?
Yes. Thank you for your question. You know, this is anecdotal, but I think it's going to drive the point across. At the time I was working, young doctor who had just freshly graduated from med school, and then I found myself, like I said, I was working at the time in Nangai Boko, the district hospital, and culturally, there is this thing that they say, you tell women that their milk is spoiled if they eat sugarcane or they are eating pineapples or some kind of thing. They'll tell you that their milk is spoiled. And so this kind of woman now will not breastfeed. And because she can't breastfeed, and at the same time she can't afford, to artificial milk, which in the quantities that her child needs, So I had this day that they brought this child who was a newborn and was in a state of severe malnutrition, simply because the mother couldn't breastfeed and at the same time couldn't afford to buy milk for her baby. That's just one case. There were legions of cases like this that I saw in my practice. And so this baby came in with diarrhea like my friend just mentioned right now. The baby comes in with diarrhea, comes in with dehydration, comes in with a lot of trouble, comes in with infections. When you don't breastfeed, you know, exactly. And you're living in that kind your baby's prone to infection. So this baby comes in with all of this. The baby I'm talking about ended up, passing away. And it was a very sad moment for me. And I think it was a defining moment for me for deciding to get into public health because I could identify a lot of issues in this one case. I could identify a lack of education that I mentioned before, so a lack of knowledge that breast milk doesn't get spoiled, unless you are in some very specific cases like HIV infection that's poorly controlled, those kind of very few those circumstances like that. But in general, breast milk is good for the baby and it doesn't go
I
bad.
think it's the best thing a baby should have.
It's the
Talking
best,
about that breastfeeding in particular,
it's the best
like
meal
it's
for
the
the
only
baby.
way a baby could have things like immunoglobulins, antibodies, because they are born with no antibodies at birth and they acquire most of them from the mother after the birth process till like 6 months.
That's right. So you could identify a problem of poverty and how it hampers on the health of individuals. Um, there were a lot of things to pick out of that case. So malnutrition was one of the things that I saw people dying for. I saw people die in that particular place in Nangaiboko of HIV. It was a major killer in that place. Again, because of beliefs that people had about the disease, because of uh, access to healthcare at the time. Treatment was not yet free of charge as it is right now. As a lot of water has gone under the bridge concerning that particular disease and its management in Cameroon. Testing was not free like it is right now.
Mhm.
So many people didn't have access to that. And for some reason, in that place, there was a lot of promiscuity. So there was a pool of. I mean, there was one time I went to the lab the to the laboratory and I flipped through the register for the number of people who had come to do their test. And out of 60 people who had taken the test, 40 were positive, 43, if I remember. Now, this doesn't mean that that was the prevalence of the zone.
Disease in the area, yeah.
But in comparison, now when I worked in the West region, for example, I did the same thing. I took the register and I flipped through, and I had just like 20% of people, it's normal to have higher numbers of positive cases in a laboratory register because people are sent there because they are already sick. But it kind of gave me you know, some kind of metric to say, oh, people are dying of this thing and in great numbers in this place. So childhood diseases, not to talk about malaria. Malaria was a terrible killer in those places. You know, you could see children dying of malaria, of malnutrition, of infectious diseases that are very common, in our setting and in that kind of place. Diseases that could be prevented by vaccines.
Yeah. So that was going to be my next question. Based on what you've discussed and highlighted, I think like one of the basic, the most serious problem is education of at the primary level. So this goes back to like primary healthcare, the people knowing some of the things they need to know, things like breast milk or things like HIV is not a tab. It's basically not a taboo. And Jim, if you have anything to highlight, also you could go ahead before I move on to the next issue or question.
Yeah, thank you. I mean, just to corroborate what Arnold has said, in Cameroon, the 10 causes of death, HIV, for example, HIV constitutes about 13% of the cause of death in Cameroon. You have respiratory tract infections, especially lower respiratory tract infections. You have diarrhea diseases, malaria, stroke, ischemic heart diseases, uh, you know, death, meningitis, and TB. Yeah, and indeed, most of these are things that could be prevented. So I am looking forward in the next part of our discussion to actually focus on how can the government, with the Ministry of Health, improve on their surveillance, improve on their public health strategic plans, and how can all this translate to reducing these indicators or reducing the cause of death of some of these infections.
Okay, great. Yeah, yeah. So, Krista, I will move to the next question. I know you've been in and out due to technical reasons. This time around, it's coming. I think it seems to be a Texas-specific technical problem. Anyway, yeah. Like one of the things that you mentioned, and I think all three of you have highlighted, is education of the people. Maybe. So, what are some of these missing parts? How can these people be educated? What do they need to be educated about? Krista, I will start with you. Then I will go back to Arnold because I know he probably has some direct experiences and some of the things he would like to add.
People need to be educated on what to do, especially when you fall sick. The first time you realize you fall sick or it's serious. When I say that, I mean when your child. Let's take a case for, let's say, a child. When your child falls sick, don't take them to TB Joshua or I don't know some doctor, common doctor around the street. When I say doctor, I mean those guys carrying medications on their head, walking around, or medicine man and all of that. Because a lot of times before patients or parents want to come to the hospital with their children, the disease has already gone too far. It's gone too far where the doctors already or the hospital already has limited access to certain things that whatever patient it is. And now when you come in there with those limited resources and the severity of your disease and it doesn't work, now you turn to blame the hospital. So education starts with realizing this person is sick and they need to go to the hospital. It's not something that you can self-treat. It's not something that you can seek for alternative measures or for people who are not healthcare professionals to get you cured. So it starts there.
And then also just to highlight your aspect on education before you continue, is that you want to tell parents to stop treating symptoms. If a child has diarrhea, they need to go to the hospital to treat the cause of the diarrhea and not just feeling that this child has diarrhea and this is what they took last time. So they are going to get the same thing.
Right. I'm actually happy because I just learned something new. I didn't know rotavirus was, one of the leading causes of diarrhea in Cameroon, because usually when you have diarrhea, it's something you can self-treat well, out here in the developed world. It's something you can self-treat. It's something you just need to rehydrate. Usually they tell you that if you have diarrhea, especially when it's bacterial diarrhea, you need to let that person go to the bathroom and
usually because infections are self-limiting.
Right, yeah, and not try to treat it and then hold it inside you and then it gets worse. I mean, it would be latent for a period, but then grow worse. So with the virus, it's kind of tricky. You actually need to go to the hospital and look for measures to get this diarrhea taken care of. So again, the first few hours, 24, 48 hours, if you're getting worse, then you need to go to the hospital. You need to get care, and then when you go to the hospital, I think for us as healthcare professionals, you need to make sure that the patient understands, what the treatment or the kind of care they should get when they leave the hospital. Let's say when you feel better and it's time to discharge you, you take your medications and you actually understand what this disease is about. So if I don't know, let's say something for the diarrhea and you get a treatment for, say, a 7-day course, let's assume it's a bacterial diarrhea, don't stop after 3 days or 4 days because you feel better and you want to save that money for, something else, or maybe the next time that you have diarrhea, because maybe next time that you have diarrhea, that medication might not work again because you did not complete the treatment and the bacteria in your body has mutated and become resistant, and now you're resistant to that drug and you cannot take that drug any longer. So we'll need to look for something else to get done with it. So we have to educate. For our own part, we really have to educate the patient and make sure that, hey, when you're going, treatment doesn't just end at the hospital. You have to complete that treatment in order not to fall sick again.
But because you feel better, you shouldn't stop taking your medication.
Right, yeah, just because you feel better doesn't mean you stop taking the medication, because when you stop taking the medication, the sickness too is smart.
Yeah.
When some of them are not dead, some of them are just, in a, I don't know, hibernative state. And after that, they grow, they mutate, and, they form something that the drug you took last time would not work this time. And
Krista, sorry for interrupting. I think that that is a subject that Jim is very passionate about. His written papers on microbial antibiotic resistance. And maybe after you, I will speak with Arnold, and then I'll probably go back to him so that we chat a bit about that subject better. And then,
Me?
Yeah. So, Arnold, your turn. Education to the consulting or to the consultant?
I'm just listening to. I see the need for education is even greater than we are imagining right now. I think in terms of health education, the one major challenge we have back from the places where we come from is, that challenge exists everywhere in the world, and even where we are right now, with anti-vaxxers, there's a lot of deconstruction of myths that has to be done, and you would only deconstruct those myths by passing a clear message that is the truth, which is a clear message that is based on current state of evidence that we have. So, but another challenge that we have, back, because when I look at from where we come from, our populations are not on the same level in terms of education, for example. So if you find yourself in a rural area and you find yourself in an urban area, the kind of way you're going to use to communicate or educate is going to be different. So
sorry for interrupting. So thank you for bringing that up. So I will request you all to speak in a language that everyone can understand, especially the audience.
Okay, so when if you go to deliver your any message on education, let me take for example HIV or even diarrhea, as we have been talking, or vaccination. You have to be able to give the message in very clear terms that correspond to the educational level of the person and in a language that the person can understand. And you can already see that that's going to be a huge challenge to educate people properly. First of all, health education needs, we have like 1,000 things out there. What am I talking about? 1 million things out there that you have to educate people on. But yes, we can decide to target like major killers, like Jim was mentioned a while ago: infectious diseases, respiratory tract diseases, all those diseases that can be prevented by vaccination. So, and most diarrheas, most infections right now have some kind of vaccine that can tackle it. So that's a huge pillar to stress upon. So we have to deconstruct a lot of myths that are out there. And as I repeat again, it goes by passing a clear message on the truth. And what I call truth is what is based on our current evidence. For example, current evidence may mean that if you take your treatment correctly, you would live.
You get well.
Yes, if it's HIV, you have to take your treatment and don't stop taking it. Now you'll be deconstructing a myth, which is like, oh, if people go and take. I saw the other day, they were on this our very Facebook and within our very network. I saw the other day they were advertising these eggs of one bushfowl like that. You know what I'm talking about? And they say if you drink that egg, if you eat it raw, or I don't know which combination, you're going to get healed from and cured from HIV. Now I just want to say, when I was working in Bafusam, covering the West region as program manager for AIDS, I saw people who were selling those eggs in the hospitals, claiming this and claiming that. Finally, they come back in a terrible state.
Yeah.
CD4 counts completely depleted, viral load blown off the roof, and then they're a few inches from the Grim Reaper. And so you see, when health education, or what I'm trying to say is, I'm painting these pictures. Health education has to be aggressive, has to be innovative, has to use methods that go beyond the traditional methods of health education, to be able to really get this message down to the people who need it. And trust me, people who need it is not only those who are not highly educated. You'll be surprised that you go to some highly educated people, but who on issues concerning disease prevention have ideas that are completely I'm still looking for a good adjective to qualify it. Yes. So we can't assume that people know.
Yeah.
We have to make the message simple. We have to use ways to get this message, to the people who need it. You can decide that I'm targeting pregnant women. I'm targeting children. I'm going to target this category of people using this kind of methods that should be innovative and matching our local realities. Yes.
So if you have some messages, how will you fine tune your message to get to the people, in terms of both training of the healthcare personnel as well as the people, the patients? Is there a specific message or a specific way you can put your message so that it gets absorbed by the people? Or are there ways that the government could modify, or strategies that the government could use? Because I know one of the adverts, I know this was a very long time ago, one of the TV commercials I used to see on TV was that parents should not talk about sex education and HIV to their children. Do we need to change those traditional dogmas? Are there are there specific things in terms of education people need, the government, I mean, in terms of the health policies, need to focus on?
Yeah, I would say, if the reality of a place is that if you come aggressively with your message makes people to retract, to draw in than to accept. It becomes a problem again. So you may be telling the truth, you may be presenting what is evidence, but you may do it in such a way that instead of people adhering to the message, they instead draw back because maybe it's not culture, it's not presented culturally. Let me take an example. I work in Adamawa region, right?
Yeah.
You know very well that condoms, for example, would prevent transmission of sexually transmitted disease and HIV, for example. But if you just go about it and say, okay, I'm going to come and do a public campaign, in a large square, in the village square, where I'm going to use a megaphone and I'll talk about these things, it may not be very acceptable. That maybe if you go through the Lamido, see right now I'm not really structuring well, but I'm just thinking you go through the Lamido, try to get people, him to adhere. You talk to a group of men together, and then you talk to a group of women together. You get a woman, to go and talk to a group of women together. You go and talk to, you know, one approach may have more success than another kind of approach. So at the same time, you're not destroying the core message, but you're packaging your core message in a kind of way that, and that's why I talk about we have to be innovative. We have to innovate. There was one time I worked with a project with ACMS. ACMS does in social marketing, and they were trying to promote the female condom, and guess where they were going to do that? In hair salons, because they know that every woman goes to do her hair at one point or the other in her life. And it was so efficient because there in that, that closed environment, women felt safe. They talk about everything, they present it there, and then it was an outlet and it was working just fine. So those are the kind of things that people were trained. The salon managers or salon managers were trained, on how to educate these women who came to do their hair, get their hair done at their various salons. And so
it will be all about targeting your specific audience. Those in need should be everywhere you go. You need to modify your message to fit your specific audience.
Yes, and then I'm talking about you are multiplying this kind of message now, not only for HIV and some components, but for you're talking about drug resistance, and these kind of things. What I've been talking about, it's a huge. There's a huge need. There's a it's in fact it's humongous. When I have to think about it.
Yeah, there seems to be a very, very big problem with drug resistance there. And I think, I wanted us to discuss this a bit later, especially drug resistance and even drugs in general. But maybe because you guys have been talking about it a lot, I'll probably bring that, we probably should chat about that now. So drug resistance generally seems to be a very, very big problem. Okay, I'm going to put one of you in the lobby and put a picture here. Then I go and ask a few questions. So Arnold, is going to be you because you've been doing the call. Yeah, okay, so thank you. Okay, so that is a picture of a typical drugstore in the streets of Cameroon. And Jim, I know you wrote an article a couple of years ago, which was published. I don't remember the journal. I think the Journal of Infectious Disease, so I don't remember. And talking about antibiotic resistance or microbial resistance to antibiotics. So I would love us to talk a bit about antibiotic resistance. Crystal, I will come to you to talk about just exposing drugs, the effect of exposing drugs like this, what that could have on the drug efficacy itself. So Jim, could you tell us a bit about what motivated you to write that article and what you found out in the field during most your studies?
Yeah, thank you so much, Terence. Indeed, antimicrobial resistance is a global health problem. Yeah, it's a big problem. It's a big problem even on the decks of the World Health Organization. And I want to cite here that when penicillin, the antibiotics, was discovered 60 years ago, it changed the way medicine was practiced, because doctors could perform their surgery knowing that they could have antibiotics to treat infections if it happened after surgery. Transfusion of blood or blood products were more effective because there were antibiotics that could, treat infections that could emanate from these procedures. Even cancer therapy management of wound and a lot of other things were more and more effective with the use of antibiotics. But the situation has changed today. Antimicrobial resistance is a growing problem, and we see it in every management of infectious diseases. Say HIV, a lot of people nowadays die of HIV, even when they are on HIV drugs because of resistance. Even common bacteria have become resistant to antibiotics. So this is a problem, and I'm well positioned in global health, and I try to take a step forward to understand the problem. And the problem is peculiar generally. It's not a Cameroonian problem. It's a global health problem. But we want to predicate our discussion in some of the things that promote the development of antimicrobial resistance within our own health system. Everyone is involved. I'm not going to point fingers here to one stakeholder and leave the other. The problem of antimicrobial resistance is a global problem, and a lot of stakeholders are involved. First is the government. There must be actual regulatory framework on the sales of antimicrobials. We're lacking that in Cameroon. That picture you saw there, I took it in the streets of Douala, actually at the central market in Douala. These guys just display drugs there. Some of the drugs are at the temperature of 35 degrees under a very hot Douala sun. They are selling it. They don't use aseptic techniques to even dispense the drugs. They use their bare hands and things like that. And that could also be a source of transmission of germs. So that's the first problem. We have a deficiency in the regulatory framework in the distribution of drugs or the use of drugs in Cameroon. The second now comes to the healthcare. You need to see the prescription of what some physicians prescribe to patients. I have seen prescription where you see a doctor prescribes about 8 antibiotics for the treatment of a particular condition. That is abuse. So I've done studies on prescription for medical personnel, physicians or nurses. It's horrible. The prescription is terrible. And then you come down to patients themselves. How do they use antimicrobials? You give them a course for 2 weeks, and after maybe 5 days, they feel better, they abandon it. And only to come back to the hospital with the same condition in a more severe manner, And then there's gross abuse of antimicrobials. Also in animal industries, they use them to, produce animal feed, and this is also pressure, and it's also the development of antimicrobial resistance. So just to wrap up, what I'm trying to say here is that antimicrobial resistance is a big problem. And it's a lot of stakeholders are involved in the problem, and to address the problem, a lot of stakeholders need to come back to the table to understand what is driving the problem or increasing the prevalence of antimicrobial resistant germs, and how we can prevent or control them.
Okay, so I have some very short questions for you, which are relatively direct. So if you were speaking to a patient who has been prescribed an antibiotic, what would be your recommendation?
Very simple. Very simple. The first thing is that I like evidence-based medicine. Before a doctor first of all prescribe an antibiotics, there must be diagnosis that, okay, this is the germ that has been identified, this is the pathogen, and this antimicrobial is prescribed to treat this infection. That has to be established. Just like the case I mentioned, where people have antibiotics to treat bacteria, to treat diarrhea. Of course, diarrhea could be caused by bacteria, and of course, antibiotics could work in that case. But what of the case if a diarrhea is caused by a virus, a rotavirus, and then the whole patient card or book is filled with antibiotics? The question here is, what are you treating? Okay, so there must be that evidence-based medicine where doctors are able to establish a diagnosis and then prescribe drugs based on their diagnosis. Some doctors do culture and sensitivity. That's good. They can isolate the bacteria and know that, okay, this is the bacteria that's responsible for this problem, and this is the antibiotics. So that's the first part of the question. The second part is the patient.
Yeah. Just before you continue, let me interrupt you. But yeah. I mean, like, the points you gave are very, very reasonable, and I think every physician should do that. But we also know that culture and sensitivity, or even identification of bacteria or the cause of infection in some places is not easy in some parts of Cameroon. So, what should a physician do in that case?
Yeah, so I agree. This is a very, very valid concern. There are physicians who are working in very remote areas where they don't even have a lab, but yet they have to treat patients. I agree with you. In those cases, they can use their best judgment to manage the infection, and that also comes back to the government. You know, it's the responsibility of the government to ensure that at least every health facility has basic, instruments for the running of the health system. But if that case happens where the physician is working in a facility where he or she doesn't have a lab, for example, to establish a diagnosis, okay, in that case, they can prescribe based on the best judgment from clinical assessment. They have no other tool left for them to be able to do their job. But in a case in a hospital setting like the provincial or the regionals, they call them now, or the central hospitals, or
primary, secondary, tertiary levels. Yeah,
health system. Those guys, they have labs, and they should be able to at least implement some evidence-based practice there. If you're a doctor working in CHU, you shouldn't be working like a doctor is working somewhere in the village where he doesn't have a health center and so on, or a laboratory. So I understand those challenges and that the physicians face in the field, and like I said, it's best judgment for them in this case. The second part of your question is for the patient.
Yep.
It's very important that patients are able to adhere to their treatment regimens. For example, if you have a prescription for 2 weeks, it's most likely that after 5 days you will feel better. But that doesn't mean that you are cured, you know. So what happens is that most patients, when they feel better after a couple of days taking an antibiotics or an antimicrobial, they don't continue the treatment. They abandon it, and then they come back to the hospital with that same condition in a more severe form. So the education here is for them to adhere to the physician's therapy or prescription until that is done. And some patients also, they do what we call auto-medication. Oh, last time I was sick, they prescribed me this drug, or they prescribed my brother or my sister this drug. I think I have a similar condition. Let me just go buy this drug and take it myself, right?
Yeah, I'm feeling exactly the same like I was feeling last time. So if I take this medication, I'm going to feel fine.
Yeah, exactly. And then they go, most likely, they don't go to a pharmacy. They go to one of those roadside hawkers or dispensers who sell these drugs, and then they buy there as much as they could afford, and they take. So all these things are helping to compound the problem of antimicrobial resistance. So to start with, education is very important. The patients need to understand that in as much as a drug is meant to treat you, that same drug can be poisonous to you. So they have to understand that they need a physician or a pharmacist's advice on how much of a drug they have to take.
Okay, great. Thank you very, very much. Crystal, I know this is a topic, a subject you are very, very passionate about. I think I saw you almost scream when you saw this picture, and you also, I think, highlighted to me that you watched a YouTube video with this same picture on it. So the problem of drug resistance. What do you have to say about this? I'll ask you this, and then the next question I have is also coming to you about. So, firstly, it's going to be drug resistance, and then you could also talk about drug stability and just the effect of just exposing drug to those conditions you see there.
Yes. To the point of drug resistance, like Mr. Ayuk has he's already talked much about it, so I wouldn't spend so much time on it. But I would say that, there's enough blame to go around, but first, and most of the blame would have to go to the government. because they are in charge of public health, and with public health, then comes, the drugs in the streets. They come in through the ports, they come in through the airport or seaport, they come in by road, and they all pass through, government officials. They don't pass through patients, they pass through the government officials first, which they are supposed to be the first line of barrier. That's the first line of defense, to us, the people getting, fake drugs or drugs that are altered. So there they get most, I would go up to even 60% of blame, going to them. And yes, the effects of these drugs being sold at the market under very harsh conditions does make the drug very unstable. Usually if you look at, I would say more than 90% or a lot of drugs, medication, tablets especially, you would always see the warning signs or the labels on it says keep in a cool, dry place. A lot of times at room temperature. Say Douala, for example. Douala is absolutely hot. There's no reason or why you should have someone in the street with drugs that, like the one you saw in the picture, selling it to the population. Because one, the drug might be unstable, or it's probably unstable, and two, it would reduce, the effectiveness of this drug for you to see that effectiveness of the drug. So let's say if one tablet is supposed to produce an effect, then you're probably going to have to take 2 tablets or 3 tablets or 4, depending on how bad it is. So that itself puts you at risk, puts you in danger, and makes you, a lot of reasons why people go to these guys on the streets is because they're cheap and they're easily accessible. But the thing is, you're just being, penny wise, pound foolish, because it's cheap now. You might see the effect of it now, but as time goes on, you might fall sick again and you'll need something stronger, which might not be in the street, and you spend more. So like what Dr. Ayuk said, it's something that we need to educate everyone on it. And what you had a second question? What was the second?
So I think you discussed most of what I asked, and so the one of the biggest issues we have these days is the opioid crisis in Cameroon. Or by opioid, I mean like most everyone knows about tramadol these days. It is a painkiller, and so many people do take it these days, especially the youth. So what can you, and Arnold, I will probably start by asking you that question. What do you think is the cause of this, and how do you think this could be regulated? Because this is a very serious, I could actually say it's a public health problem now in Cameroon.
That's a good question, because we happen to, by the fate of circumstances, we find ourselves in this part of the world where the opioid epidemic, it's receiving a lot of funding here and there. I mean, even where I work right now, it's the happening thing. Every data analyst, every program manager wants to go into anything that has to do with the opioid epidemic. And then you'll be thinking, oh, okay, this is a reality that's happening this side of the world, and you're not expecting to hear, that it's happening back home. And then suddenly you start getting things like a country like Nigeria next door. It's blown out of proportions. In Cameroon, it's there. I've actually seen people convulse in front of me. And so when your question that comes to say what's the cause and why, it's not because somebody had some disease condition that the person had to take, very powerful painkillers to help them with their pain. So it's more along the lines of, addiction, pure and simple, And I think the population, if you look at the population, it's more of youths, and I would stray without having all my facts. I would stray to say young males, because at least in my small anecdotal evidence, which is a very very small scale on scientific evidence, that's my observation. And the most of the time, street kids, uh, unemployed, unemployed youths, will get into the habit of taking substances. And I think the hype that goes behind the substance as something that can multiply, sexual prowess. Because I also think that's one of the things that get people hooked on it.
Yeah, I'll probably ask you and Crystal to like tell us the long-term effects of these drugs on the consumers. I think because I'm sure most of the people, yeah, this is just an anecdotal thought as well. Most of the people taking these medications don't know the long-term effects of these medication. So, in your experience, so you and Krista, what are some of the long-term experiences, long-term consequences of these drugs, especially the opioids? So you mentioned about addiction.
Yeah, I mean, when we look at the long-term effects that's feared everywhere, it leads to high levels of mortality. That's what, when we talk about the opioid epidemic, it's these high levels of mortality. If you have been listening recently, they said the lifespan, average lifespan of a typical American has gone low, has reduced in the past couple decade, because the culprit in this case has been, opioids. And so we would be saying that's the most feared long-term consequences. It kills. It literally kills. And then beyond that, if you have to take people, to pull them out of addiction, it has a cost. It has a cost on health systems. It has a cost on it has a cost on health systems. It has a cost on that has to be incurred by someone. That has to be incurred by someone. And that is, each time you have something like that in public health, some additional cost that has to be incurred in someone, it means you are diverting funds from other that can be used to combating other, I would say, serious, conditions, towards diverting those funds to combat something like that. Crystal mentioned something that I liked. The boundaries of a country are not controlled by individuals; they're controlled by the government. And so, I'm going to point the finger and say, these are things that the government has to put their foot on the ground and say, this thing should not find itself in the territory.
Okay, great. Thank you very much. So, Krista, I'll be asking you the same question because you probably would know, tell us a bit of some of the psychosocial consequences of this drugs. But before I continue, I would like to welcome our fourth guest for today. She is Dr. Christabel Ngwashi. She's a physician and a health blogger, and she's aspiring to pursue a career in what Arnold has achieved, which is global health policy. She's also a founder and seeks to develop physicians being curative and hospital-based medicine, thereby strengthening preventive and community healthcare. And so that is one of the, I've been looking through the comments, and someone, Peter Sako, I should precise, have been talking about a lot about education and preventive medicine. She's also an alumni of the Cameroon Leadership Academy, and most recently won the World Bank, I believe the World Bank award for health blogging. So welcome, Christabel, and thank you for accepting our invitation. I would like to apologize giving you the wrong time in the first place.
I know. Thank you very much, and I'm very sorry for coming on late. It's due to reasons beyond my control, and of course the time. So I planned for a later time, and then all of this. So I'm very sorry for keeping you up. But I see you've gone ahead, so I'll just pick up from where you all started.
Okay, cool. Yeah, thank you very much. Okay, so yeah, I will continue from where I was. So, Crystal, I'll go with you then. I think Christabel had mentioned to me like she has a very, very strong interest in health health policy, and that is going to be our next item. So I'll finish with you now, and then we'll pick up from there. So, Crystal, could you tell the audience or some of the people watching out there's some of the long-term consequences of some of this drug abuse? In this case, the case of tramadol in particular.
Long-term consequences: depression. You have depression. You have kidney disease because it can cause urinary retentions, and you can have UTI infections and all of that. Anxiety. Anxiety, due to addiction, where you would, instead of taking tramadol, now we're trying to
something stronger.
Treat tramadol and some other, treat the pain or the consequences from tramadol, and you're taking some other medication which is also addictive, and you're combining both medications. It also causes a sexual dysfunction, where it causes erectile dysfunction, it takes you long to reach orgasm.
Ouch.
So guess what? I think a lot of times, a lot of people will take it for sexual reasons, because if you have premature ejaculation, this is the medication for you, but I mean, for everybody else, it's annoying because you have to wait for this person this long to get to orgasm. So it might be good for you short term, but again, you're not getting the pleasure, like maximum pleasure you're supposed to get. And at the end of the day, you're going to get a sexual dysfunction, erectile dysfunction as time goes on. And worst case scenario, death.
Yeah. Okay, so thank you. You guys have had psychosis, erectile dysfunction, and addiction, which is one of the biggest problems. You don't want to be addicted. So if someone is on tramadol and someone is addicted, what advice would you give to them? How do they get out from those drugs? Because addiction is a serious problem, and like to leave a drug you are addicted to needs something special. So what are some of the recommendations or suggestions you could throw out there? I mean, any one of you, could interject.
Personally, I am not very sure there are resources right now. It's something that's just springing out right now, and in to my knowledge, to the best of my knowledge right now, I'm not very certain there are resources that have been set up to be able to contain these cases as they'll be coming in. Probably someone is sitting somewhere right now and trying to see whether they can have something going on for people.
I did a literature search and I really didn't see that much information.
Yes.
All what was mentioned was
my best advice right now would be that if someone has someone going through this, the best advice is to go to a hospital, and then depending on Jim spoke a while ago about we have a pyramidal system, central, regional, and then district level. Depending on where you find yourself, you may have to be referred to a higher structure that may have a specialist who has training, dealing with usually addiction medicine. It's the specialty of psychiatrists, and it's their domain. So I want to say the same, that if you have someone right now, your best bet will have to go to the hospital, and then try to work your way towards this specialist. I mean, we compare. Otherwise, here we have it's injections that are available for people. Like back when I was in school, you could sign up to be a volunteer and carry a pen and give a shot to someone that you saw on the roadside having a seizure or having some kind of But we don't have that. So my best bet is to take that person to a hospital and work
Let
your
me
way up.
just add. Let me just add to what the doctor is saying. As he rightly said, I don't know if you're finished talking.
That's okay. Yeah, go ahead. Yeah.
Yeah. Okay.
You
Okay.
probably need to. You probably have more airtime to talk to me up with what.
Okay. Okay. Just to add to what he's saying, he says that you should see a specialist, of course, a psychiatric. The problem is most hospitals do not have that. So I always advise people to use counselors because with the systems being placed now, especially with the spread of HIV, they try to make it possible for each treatment center to have a counselor. And up to this point, at least I'm sure that even health centers have treatment centers who have nurses as counselors. So the first thing I think that somebody can do is you should talk to someone. I think that people are getting more aware about drug abuse, that you can even see a sibling, you can even talk to a friend, you can even confide in somebody who is very close to you, because people don't open up easily to doctors to come to the hospital to say, I am addicted to drugs. So it's better you confide in somebody that you're very close to or who you feel comfortable talking to. When you talk with that person, the person at least will be able to establish maybe why you started, what's the reason why you were doing it, and from there people can take the person can be able the person maybe can convince you to go to a hospital, or maybe both of you should see a specialist. At least in the company of that person you have confidence in, I think that you'll find it easy for the person to speak up. And then secondly, your company. I think that that people sometimes you have peer pressure, or you have your company that you keep. If you should try to establish that is the company I'm keeping actually contributing to this addiction. So you should try to withdraw from the company, and maybe also, and of course, while you're in the process of rehabilitation. And then finally, you should be able to. I'm sure most people who even take these drugs are educated to an extent, so they able to read about just be able to have a knowledge of the side effects. So you using your own logic, you'll be able to weigh the side effects and the effects that you have, and actually see that, okay, do I really want to end up with the effects that Dr. Krista was talking about? Do I really want to get addicted, having sexual addiction, or having sexual dysfunction and all of that? So I think that with that, and with a lot of sensitization going on, trying to make everybody at least some kind of counselor. So I would just advise that you should follow those steps, talk to someone. If the person can be able, the people can go to the hospital, you check your company, and then you go on the process of rehabilitation. I just think that could be a first step towards
Great. Thank
getting
you
out.
very much for that. And Crystal, do you have something to add?
Yes, just a little bit to add. Everybody has said most of what I had to say, but what I would maybe differ in is please don't get addicted. Because once you get addicted to these drugs, there is little or nothing that can be done in Cameroon. I searched to see if we had maybe something for an addiction center or hospital. There is none. There is nothing. I think I came across a video where where there was something like a center or like a little clinic or health center in Douala, but they said that was the only clinic in the entire Cameroon. So the stage at which we are with drug addiction is, I would compare it to maybe the stage where we were at with AIDS in Cameroon in the 90s, where there was almost very little people could do. So once you get addicted, there's little help. You will have little help from your healthcare providers. So this is something that we really, really need to again go back to our community and educate the people. And now we're even seeing a rise. I'm thinking maybe in a few years to come, we would see the use of tramadol even way higher than marijuana, because marijuana is something illegal. It's something I'm sure. I don't know what the cost is, because right now marijuana is the most abused drug in Cameroon. Then you have tramadol, but marijuana is illegal, so you can't just walk around with marijuana. But you can walk around with tramadol. And tramadol is cheap. So right, so people might leave from marijuana and move to tramadol, and hey.
So I'm thinking, sorry for it. So I'm thinking from a health policy point of view, and I'll probably bring Arnold in as well from a health policy point of view. And Jim has mentioned something about that earlier. The issue here also, I think this should be something of cardinal significance, because it's all about the availability of the drugs. How do these drugs get to the patient? Because like those are very strong drugs. We should only be available on a prescription. Tramadol in particular should only be given to patients. So how did we get to the extent of an epidemic? Because it's an epidemic.
Honestly, what can I say? I think there's our boundaries seem to be very porous to lots of stuff. Current happenings in the country now tell us that our boundaries are very porous to a lot of stuff, and as much as it affects other sectors, we are now seeing that it affects the health sector a lot. And it's either something is done. In public health, we usually say that it's some problems that you find in health are not exactly health-related problems.
Yep.
For example, a lack of running water. It's a health problem, but upstream, it's not a health problem, because it's not people of health that are going to provide
managed water. Yeah,
exactly. So again, when if you consider the situation of how does it happen, first of all, that you can find a molecule like tramadol on the streets, and then in the quantities that you have. I know that next door Nigeria has, ours is probably a small scale compared to what they are facing right now there.
Mm-hmm.
And my wild guess is that a lot of what's circulating in Cameroon comes from through that direction. It's a wild guess, I'm not very sure.
Yeah, that could be true, but like a couple of months ago, or maybe I read an article of a very big chunk of drugs that were seized by customs at the Douala airport.
Yes.
Those weren't coming from, I don't know exactly where they were coming from, but definitely not from Nigeria. So the boundaries are porous. I totally agree, but they are most likely coming from elsewhere.
Exactly. That's what I was saying, that our boundaries are porous to a lot of stuff coming from places and through and by people that me as citizen X or citizen Lambda, it's hard to know. But I'll take another wild guess is that these people are known. These things don't happen, It doesn't just happen, If a huge consignment like that was seized, it's because somebody probably tipped it away, or somebody probably did not pay what they were supposed to pay. That's how things usually happen. And then because they didn't pay what they were supposed to pay, someone says, "Okay, I'm going to mess up. I'm going to mess up the entire scheme." And then you get these things being intercepted. But I think we have to do better. We have to do better, and that's why I spoke about governance as one of the issues I identified, as problems in our health system. If we hope to make some kind of long-term, solid progress, we must address that issue. We must address the issue, and like I said, it trickles down. Those are problems that are not exactly health. There are health problems that are not exactly, the origin doesn't lie exactly within town. And then when you come again further down, because you spoke about policy, when you come again further down, I think since we are in the kind of our health system is pyramidal, the central level making strategic decisions. I think again at that level, there's a whole division of pharmacy and medicines at at the Ministry of Health. I think that strong policies have to be put in place. Um, Hospitals and pharmacies and outlets for medications in general, they has to have stronger control. I don't know how they're going to do it. I'm not very savvy in that domain, but what I know is that stronger control has to be put in place to be able to track medicines correctly. To be able to secure medicine so that it doesn't land in the hand of any kind of person. Right now, you can walk into most outlets for medicine. I say outlets for medicine. I'm talking about pharmacies. I'm talking about hospitals. And even roadside.
Don't forget the streets as well.
And that's why I say, and even roadside
Yeah.
pharmacies. You can walk to any of those places and get and buy whatever medicine without prescription. In many places, that is possible. And I think strong policies have to be put in place and enforced so that people don't get access to medicines on a whim. I think one of the pillars is access to essential medicines
Yeah.
and of a health system, and you just can't play with that aspect because anti uh, antibiotics resistance also stems finds one of its roots in that access to medicine by any kind of person without a prescription, any any hands. So I think those are things our country will have to be thinking about very, very seriously and working on very seriously.
Okay, great. Thank you. Christabel, do you have anything to add? I actually have to ask you some of the questions I asked the other guys. And like one of the main questions I asked at the beginning was, I mean, like you have now hands-on experience in the field. So what are some of your experiences of the healthcare system? What are challenges you encounter? And also, could you highlight us some of now with the health policy aspect, some of the recommendations in terms of the policy?
Okay. Okay, with regards to experience, do you mean my experience in drug addiction
No,
or
the healthcare system generally. So I asked these
oh,
guys that question when we started. So I don't want you to go home and saying that I didn't ask you the same questions I asked. But like the reason in reality, the reason I asked you this question is mainly because I know amongst all of us here, the only person who is working on the ground now and meeting patients every day in Cameroon is you. So I think you probably have a better feel of the situation now. So that's why I went back to that
okay.
question. I've just proceeded.
Okay. Of course, we know how the healthcare system in Cameroon is. The hardest, the difficulty we all faced is, of course, infrastructure. As much as you have it written in papers that it's supposed to be organized like this, like this, like this, it's not what actually is being done. We know a lot of paperwork is being done, but when it comes to being implemented, we see that there are a lot of loopholes. So the first thing is, of course, infrastructure. We don't have a lot of the resources that was supposed to be working. It was supposed to be working with, and as such, you're left with very, let's say, limited resources, and as such, you have to improvise with a lot of things. Imagine you having a premature baby in a village. I actually say this out of experience from a friend, and you actually have to make an incubator out of a carton. So he felt that no roads for the person to even reach the referral hospital, and even if the person has the possibility to reach, the person does not have the finances. So there's a problem of infrastructure, there's a problem of access. People don't yet have that that's the amount of healthcare insurance coverage does not really cover the lay person. You'll be surprised that ironically in Cameroon, health
I think you are breaking there.
Has pocket expenditure, which is one of the hindrances to us. I don't know. Are you getting me now?
Yeah. Yes. Yeah. Can you speak a bit? Let's see.
Okay. I mean, one of the problems.
Yes, I think. Oh, you are still breaking.
Is are you getting now?
No, you are still breaking. Okay, let me bring Arnold. I think you can join back, but I think that what you were saying is like something what I really wanted to hear, and I believe the audience were really excited and willing to listen to you. So I will bring in Arnold, and then you can come back and pen a bit on your points again, if that's okay.
Okay. Yeah, that's okay. That's fine.
All right. It seems as if it's clear now, so let's give it a shot again.
Okay.
Yeah, to the audience, to forgive our technical. It's internet everywhere, so we are hosting from somewhere, and we have people all around the world. So sometimes we have technical issues like this because we are not sitting on the same table. So our sincere apologies for this. Okay, Christabel, you go ahead.
Okay, I'll say the first problem is resources, available resources to be able to provide services that we have to provide. Then secondly, I'm talking of accessibility of the population to the healthcare services that are available. For example, 80% of people still having to do out-of-pocket expenditure. That's
Yeah. I think we are
still has to use its available let me say resource.
Yeah, we are still experiencing some technical issues. So, Christabel, yeah, you can wait a moment. Let's see if you could sort that out, and you can join us in a moment. Yeah, Arnold, I think you had mentioned to me you are a big fan of accessibility to healthcare, and by accessibility, you have always insisted on healthcare for everyone or healthcare for all by any means. So, in terms of government, policy, or let me just say policy for that point of for that aspect, what are some of the policies which can be put in place to improve the healthcare of the ordinary citizen?
Wow.
Yeah, I know that's a very huge question, and I'll bring you. I know you have a strong interest in policy. Christabel also has a very, very strong interest in policy, as you mentioned to me. So I'll bring her back. Hopefully, we'll be able to sort out a technical issue.
Yeah, thank you for that question. I became a firm believer of health for all when I realized that health is a right. The day it dawned on me that someone should not be in better health because they're richer, and another person should be in poorer health because they were poorer. The day my eyes opened to that truth, I became a firm believer of health care and health for all. And so, right now in Cameroon, I know there are ongoing works on how to bring that to come to pass. In Cameroon now, there's a lot that's going on there. But what are those things? There's some people who believe that in health for all, we should start small and then gently get progressively scale up. Progressively scale up, so we can get everyone to come on board. Maybe that's a good work for like us. Now, what has
who is that coming from?
One of those things come to mind. Just around the time when I left, there was this new program that was being brought, which was I'm forgetting the name, but the idea behind it was that pregnant women will be followed from the beginning of their pregnancies to the end of their pregnancies for a cost of 6,000 francs. And that package, that 6,000 francs, would involve everything. Would involve would take would pay for their antenatal visits, for their medications, for whatever they need, for their vitamins, antenatal vitamins, and even in the occasion that they would have to get a cesarean and a cesarean, delivery at the end of that pregnancy. All of that was covered by that 6,000. The idea was that the whole package costs 60,000, and the patient was supposed to, pay only 1/10 of that, which was 6,000 francs, and you were not supposed to pay the 6,000 in one installment. You could pay it out. I think you could split it and pay it out over 4 installments or so. I'm forgetting the details.
Okay.
Now, that was a small scale. It was funded by, and that's another thing now we'll probably touch today if we have time. How do you finance all of that?
Exactly. I was going to ask that question, how you finance that actually. 6,000 francs, all pregnant women, that is more than $10.
The financing of that was coming from one of those CDD funds, that C2DOC, CDD, that was coming from one of those colonial masters that we don't like very much. But yeah, that was that was the idea. But anyways, so and then it had to be piloted in 2 regions, the 3 northern regions, and that idea for me is how health for all has to start and then grow by targeting populations that, those categories in our populations.
The vulnerable population. So things like children, pregnant women.
Thank you.
Aged.
And begin to put into place, strategies like this that hopefully will be evidence-based to reduce, unfavorable outcomes and increase favorable outcomes. And then as we begin to put those things in place and recruiting more people on board, it will grow and to capture 100% of the population. Obviously, the kind of health for all I'm fan of is, so it has its limitations, but the kind I'm fan of is a single payer system.
The last time the WHO tried that health for all by the year 2000, they didn't achieve that.
They didn't. It's going to take long. I'm fan of a single payer system where, you walk into a health facility and you don't have to worry about what am I going to become as I walk in there and when I'm walking out. What, because the whole idea is you having healthcare without it having an economic impact on you.
Yeah. So what can the government do here? Because I know recently, I read a couple of papers in the last few days that people were locked up in the hospital, particularly in Yaoundé, who were unable to pay their hospital bills. Yeah. So that was very depressing when I read those. So what, you, a believer of health for all to some extent, where do we get all? Should the government get all this money? Health is actually, in as much as the right, as you mentioned, it's expensive as well.
That's right. So funding for healthcare in Cameroon right now, I think you have 4 sources. You have four sources of funding. Most of the funding of our healthcare is out of pocket. So it's the individual. I think, if I'm not mistaken, it's close to 50%. Then
it's
the next
70%.
Okay, so then the next one is the state. The state has about 33% of that amount that it contributes, and then you have external funding from all those other partners, international funding that comes in. I've forgotten the percentage, and then what's what's the last? And then private, private funding from private structures for healthcare. So that's the cake of it right now. The last figures show that it's about 6%. Maybe Christabel is going to say more about that.
Mhm.
We spend about 6% of the GDP on health. Now, any country that knows that they are going to make any important strides, and if we have to lay down universal healthcare for all, that money has to go over 10%. I don't know how much we'll have to be injecting, but as a country, we would have to think about the amount of money. I know a country like the US, it's like, I hope I'm not making a mistake, it's around the 20%. It's around the 20%. So I think we have to, the state will have to look for a way to increase the amount it's putting into health right now. If we have to dream of, because it's a dream that is going to touch all of us, So if that aspect of financing has to increase, probably the financing from private sources has to increase, and then financing from out of pocket has to increase. It has to, because it's universal healthcare we're talking about. But so other ways of innovative funding will have to be thought. We'll have to think of other ways. I have a friend who used to say jokingly that if we had to collect 5 francs of from every bottle of beer that was sold in Cameroon, that was going to go a long way. I've not done any calculation on that.
And I think that's a brilliant idea, because we've mentioned drug of abuse, we mentioned tramadol, but alcohol abuse is actually a drug of abuse, and it's a very, very serious problem in that country. I mean, it's a more serious problem than tramadol, I may say. That with like 60 degrees of confidence.
I usually also jokingly say that the whole country is on diazepam, and the diazepam is alcohol. Yes, we're all half asleep because of alcohol.
Yeah, diazepam is Valium, what people commonly call Valium. So
yes,
audience, yeah.
I would say the whole country is on volume, and that volume is in the bottle. I don't know how we're going to do to come out of that one, because it looks like a pillar. People say choose your battles. I don't know whether alcohol addiction is a battle I am ready to engage myself on right now, because when I look at it, it's just crazy. It's just crazy.
Okay. Krista, I don't know if I should bring you in. I'll probably bring you in terms of the policy for the exposure of drugs. It was going to be Christabel, but I think she just disappeared and will be joining soon. As soon as she joins, she will. I will ask her to elaborate to me to the audience, actually, some of the policies she will recommend to the public service to be implemented. But to you, like you've seen, like I presented that picture here, how drugs are being sold by everyone in the street, incomplete doses. What policies could be put in place for this sector to be regulated, at least?
Well, before I answer that question, let me go back to tramadol, because I see there's a couple of people asking questions here, what we could do, and not to stop blaming the government, or not putting too much blame on the borders and all whatnot. Let me try to explain. Drug addiction is bad. When we say drug addiction, especially to those who are not healthcare professionals, it means I would do anything or everything to get that drug. So if I need one pill, if I need a tramadol, I could sell you, I could kill you just to get that tramadol. So that's how bad drug addiction is. The tramadol industry or the drug industry, I think they make $75 billion worldwide. That's how much. It's even more lucrative than say the cocaines and heroines and all whatnot. Those are not tramadol, but counterfeit drugs and all those cheap drugs and fake drugs. And tramadol, China, India, that's where most of them come. When they come, they pass through again. The borders, that's your first line of defense.
Yeah. Krista, you two are breaking. It's not a Christabel's problem only. Okay, I'll take Krista out. I think she sorts out her internet issues, and then maybe I will throw the same question to Jim. He has a few things to talk about what could be done in regulation, especially of the alcohol. The antibiotic abuse. What policies could be put in place to regulate this particular problem? I mean, generally the sales of drugs, how drugs are handled, who sells drugs.
Yeah, thank you, Dr. T. This is a very, very interesting question, and the answer is very complex. It's not a very easy decision or solution even for the government itself. If I take a little bit of statistics, just imagine the hundreds of vendors in Douala, in Yaoundé, in Bafoussam, in all the provinces or regions, as they call them now. If you move those guys off the street, okay, I know people who have been doing that for about 20 years.
It's a career.
It's a career. If you take them off the street, you're going to definitely have something to provide them. So in as much as we want the government to fix this, it must be done in a prudent way. So here are some tips. The first thing is there must be a regulatory framework as to who is licensed to sell a drug. And all these guys who are already in the corridors or the business of selling drugs, they can be encouraged to get education on not as pharmacists, of course, but as drug vendors. In this case, they can get knowledge on how to preserve drugs. And then it's the government responsibility to regulate the influx of drugs in the market, on the market in the first place, because most of these folks, the way where they buy their drugs, you'll be surprised. If you go to the pharmacy and you buy a packet of a drug of say 5,000, or let me say 10,000, these guys will give you that same drug for 1,500. I asked myself, but I mean, this looks the same, but how come the price difference? You know, so they have their own channel where they get the drugs, as well as the pharmacies have their own channel where they get the drugs. So, but who is responsible here is the government to either build up regulations into access. How do drugs first of all come into the market or into the country? Who are those authorized to sell these drugs? What are the requirements that they need for them to have this authorization to sell drugs? So the government needs to fix that. And all these guys who are interested in sales or in dispensing of drugs, they have to have authorization. If you're not authorized, you don't need to be on the street selling drugs. That's the first thing. So that regulatory framework, it's very important from the side of the government. That regulatory institution or infrastructure needs to be in place. It is happening now, but it's not enforced. Of course, they have a directorate that is in charge with that. They do have it, but it's not enforced. So it has to be enforced. And the second thing is for patients or for the population themselves to understand the repercussions. You can have an antibiotic flying the street at 37 degrees centigrade or another medication. The integrity of the drug is destroyed, and that same drug cannot be effective Because if you look at the path of most medications, they have indications where they have to be stored. Maybe in the fridge at 2 to 8 degrees, maybe at room temperature below 25 degrees.
Yeah.
But the temperature in Douala and the streets, you know it better than I do in the hot Sunday or hot dry season. It can go up to 37 degrees. So what happens to those medications that are sold at that temperature? They are no longer effective, or at least they have lost their potency to some degree. So patients need to understand that they are not doing any good to themselves in as much as they want a medication that's cheap by getting it on the streets, because those drugs are not preserved adequately. So the drugs are likely to lose their potency, and they will not help them as much as they want to. Yeah. So I see it from both the regulatory standpoint as well as from the population standpoint.
And to highlight your discussion or the issue of authorization, I would also recommend that in giving such authorization, especially for those who are selling the drugs on the street, there should be some requisite requirements. At least you should do some basic training, even if it means it's the Ministry of Health organizing some training on how you distribute drugs, on how you store drugs, or even handling of drugs will be very helpful, because it, like you mentioned, just taking those guys out of the street is going to cause a lot of chaos, at least to the economy and to the family.
Can I say something?
Go ahead,
I just want to say that it's throwing some water on your grindstone. In Nigeria next door, it's they have been included into the health system as actors, because they realize that the way they are now implanted, it will cause a lot of havoc to try to combat, to do a kind of repression, so they are incorporating them into the system and trying to use them alongside other resources. And I think that's how we have to probably think through some of these challenges when they come up in our health systems. I was impressed. It's difficult to regulate a sector that is by essence
are dysregulated.
Yes, dysregulated. But I think we have to think of ways to overcome those hurdles, because the truth is they have been actors. There have been actors there, whether they have been appropriate actors or not, but they have been there. And so just adding water to say that it's been done elsewhere, and I think we can borrow experiences from elsewhere and shape it into our own.
I think that's a very, very fair point, because in some places, in some remote places, not even remote, there are no pharmacies.
That's right.
These are the people who supply the medications, and so if they are included as part of the actors in the healthcare system, that will go a long way. What the policymakers just need to do is give them some education or some requisite requirements that they need to meet in order to become such actors. And okay, so Christabel, now that you are back, you started giving us some very, very interesting points on what some of the recommendations or in terms of policy that you can give to modernize or to amend the broken healthcare system. So if you attend, hopefully your technical issues have been sorted, and I will leave you to talk and talk.
I hope so. I hope so. So for recommendations, is it okay?
Yeah, go ahead. Yeah, it sounds good.
Okay. They should increase the amount of the budget that goes into healthcare, because currently in Cameroon, it's actually, from the last record I actually saw online, which is 2016, they said that allocated 3.6. So it's very, very, very insufficient to be able to tackle all the challenges that come. We have problems with infrastructure. We have problems.
Sorry, just to interrupt you. It used to be 5.6% of the budget in 1987. Mm-hmm. It decreased to 4.4 in 92. And now, like you mentioned, you said it's 3.3?
3.6. The last one I read, that was in 2016. I don't know for 2017, 2018.
Okay. Yeah, so go ahead. I just wanted the audience to know how it's been shrinking over time.
Yeah. So it's actually we actually, if the government could actually see that they increase the amount of money that is being diverted to healthcare delivery, I think it's going to go a long way. And then secondly, I think there's something which Rwanda is doing now, which has actually helped them in reaching about 90% of the universal healthcare coverage, which they call community people in a particular community contribute money, give it to their traditional rulers or somebody who the community actually chooses. That money is being controlled by the community and they use it to be able to fund their healthcare in that particular community. I couldn't really get a grasp of it very well, but that's actually the summary which was given to us during the AHEC conference in Kigali. So that's what Rwanda is actually doing, actually coming up with a micro insurance program to actually help the least, that's the most, let me say, okay, the poorest person. So I think that with that, we should not just wait on the government to come up with a program that, it's free for this person, or it's free for because we'll write it on paper, but it will never be implemented. Like Dr. Arnold was saying, he said that they said 6,000 for women for antenatal, but I can tell you that it is not happening. Women still have to pay about 13,000 to register. So some other, so it's actually not functional. It may be on paper, but it's never implemented. So I think that this micro insurance program will actually go a long way. And then thirdly, I think technology as well. We have that infrastructure for technology. Like now, I'm struggling with internet. Some more of me having to do maybe telemedicine, consult somebody in a remote area, which is not going to be very possible. But I think that if we make use of digital technology, it can go a whole long way in actually achieving this universal healthcare coverage. So that will be my own recommendations. That's increasing the annual budget, micro insurance program to be able to serve the poorest people. That's people at the bottom of the ladder. And then thirdly, the use of digital technology. I think if we have to actually achieve universal healthcare coverage, those three things, if we actually leverage on all of them, then I think that it can go into improving infrastructure, improving accessibility, and as such as also increasing affordability.
Affordability, yeah, great. Okay, thank you very, very much. So we've discussed a bit about some of the things that can be done in terms of policy to improve healthcare. But most recently, what we have noticed in Cameroon, as well as many developing countries, is a surge or the rise in what I call the metabolic epidemic. So this includes the rise in cardiovascular disease and cardiovascular disease, obesity, as well as type 2 diabetes mellitus. So I have a few questions for you guys, physicians, and some of them are going to be very direct. Some of them will need some an explanation. So Arnold, I'll start with you. So can you tell us what diabetes is?
Oh.
I mean, in the layman, so that someone listening in the street will know that, okay, because one of the biggest problems with type 2 diabetes in particular in the developing countries and in Cameroon, from some of the literature I try to read, is that some of the people suffering from this disease don't even know they have diabetes.
That's right.
So, yeah, so that's why I'm asking that question, so that you can probably, maybe someone will be listening and will tell someone who is not here today.
Okay.
And use a language that they will understand.
Thank you. That's what I was about to say. Thank you for precising.
I don't mind pidgin, honestly.
Thank you for precising the spirit of the question. So it makes me to load my education.
Education hat. Yeah.
Yes. So. And I just want to mention that diabetes was my first love and will remain forever my love. Diabetes now when sugar don't increase your blood. So normally all man get sugar for blood, but that sugar for inside blood maybe pass on certain level because your body get way for control that sugar, get way for manage that sugar, may not plenty, may the sugar not pass on certain level. Blood get plenty tonight, it circulate inside. You understand? We must get plenty things inside sugar now one of them. And body they ever try or keep thing the way they circulate inside for some certain level. Because when the thing then pass on certain level, if it cause problems. And sugar now one of that thing that when it plenty for your blood, it cause trouble. And the problem with diabetes now say when that sugar don't increase, it dey attack all side for your body, your brain, your eyes, your heart, your kidney, your nerves in general. That cable them for your body where they dey transport information, will dey attack them. So when you don't attack all that thing, so it can really be dangerous. And normally, like any kind sick, when you get diabetes, it go show. Understand? It will come with the symptoms. So now most of the time people they go say, oh, when the hear say someone dey piss plenty, when the hear say someone start piss plenty,
Yeah.
people they go say, oh, go do your blood, go maybe check your blood sugar.
So diabetes now one of that kind of stick way to make a man go piss plenty.
Most of the time that's how it start, but not like the only way that way it can start. If it start differently, but most of the time it is start now say you dey start piss plenty, and piss plenty now either you dey piss plenty. So most of the time people don't realize and say for night they dey wake up like 5 times to go piss. So it not means if you wake up 2 times go piss no problem. But if you see and say it's not to wake up like 5 times to go piss for night, that time if it is okay, time not reach for me for go for hospital, go check what it happen. Man go talk say that the things where they hamburg me, man check how it happen. So as I talk now, the main way, now the major way now diabetes happen, but some people then will get whatever to say now three major symptoms where you will feel on your skin. You know, for no say they say if you drink plenty water, if you piss plenty, and if you chop plenty, because sugar na petrol for body. So when that sugar don't plenty for your blood try for move the excess sugar. It go piss some inside. So it go send and make come inside piss. But the problem I say when you piss now that fuel, you need to get enough. Yes, you need to get enough for burner, me a motor, me a engine worker. So you'll get for the chop plenty for compensate. So now so that 3 symptoms. But again, you feel start and say you lost weight. If you realize you don't lose weight, in a very short period of time, you don't lost plenty weight. So if you start to see that kind of symptom, then run, go for hospital. Normally, they don't say once you don't reach 40, begin to go maybe to check. Not even wait for reach that full symptom. But
and so we will not give numbers here because I know one may any person come here go test himself or
now I not talk call number.
Not this one or not this one or not this number. But for you for become for call you say you get diabetes, you get some particular number where your glucose therefore reach and a person. And then another parameter in 2 day, another thing in 2 day where they're looking for their blood. Another one that they call and say hemoglobin A1C when a sugar the modifier hemoglobin where they carry when they carry oxygen for your skin to increase. So I get another question.
For Adam. Sometimes because some person think that also when I go hospital, they do that blood sugar. Then they tell me say I drink sugar again. Now just for Adam say if they do they go check your sugar. It not check fine with the head. They say no, will not be very sure whether not diabetes or whether not be diabetes. They feel make them so other tests they will make them will give you sugar. You go drink, then they go now check that sugar again over the next 2 hours. You get some long complicated name, oral glucose tolerance test, but yes, don't know say if you need if you want to check them, then they need to do that test again. They know whether.
So, what is the cost? I mean, like over the past few years, there has been a rapid rise in the number of type 2 diabetes patients. Some of them are even undiagnosed. So what is causing this increase? I mean, it's not only in Cameroon, but worldwide. But in Africa, there seem to be a sudden surge.
Yes. We get someone we get someone who some theory will be because diabetes probably increase for place like because we get some famous doctor if you can check from the early 19th century 20 from 19 something 1905 or so because he barely see one case for diabetes. But now if you want can check out, you don't increase. The last number they show say 6% for urban region of Cameroon. 6% of people that get diabetes. Now, that's it plains itself as a prevalence for HIV. We call prevalence of HIV for big place and 4%. The days of diabetes and 6%. It means it mean plenty pass. So wait if you make it go up. For no waste time, we'll go say right now, we don't change the way we chop and we don't change the way we shake. We don't change the way we chop, we don't change our diet. Our diet don't slowly transition from traditional way we chop. We don't incorporate, we don't incorporate some kind of imported diets and that kind of thing. We don't change the way we chop. We don't change the way we shake. When I talk we don't change the way we shake, it means say we need the physical exercise. We need to do them as we do them before. For many reasons. One of the reasons I say people feel now say for work on foot.
A
poor man thing. Now Okada don't come. Yeah, Okada don't come. He can't drop you for your door. You just wake up, jump your gutter. That gutter is the part of front house. You enter inside a parlor. All that thing don't make people they need to move. If you be able to walk 5 kilometers for go market, now you just come up. Hey, Okada man, he can pick you for side the stand. He go drop you for front the place you buy Gary, turn, you come out of house.
So the doctor be here say if man get big belly na find him. Not true.
Yeah. That belly na serious trouble. Now in those days, we say belly fine. But now so now so if your belly big, only the person already just go try for press and make the belly reduce, because that belly so na sign it show say you dey at risk for get sick like diabetes, especially belly for man picking them. Especially belly for man picking, it shows you dey at risk for get diabetes. So
Belly that way young boy they drink beer so she don't forget belly come up. That kind belly it all.
Now that pregnancy belly, no, that belly for man picking, that pregnancy belly where it don't reach 5 months. When man picking reach the belly get 5 months size. No say that one not good again. So you therefore start go the work and when that belly you reduce the go. Because that belly on a sign for sure say that thing will control make sugar not go up for body. We call and say insulin. I feel mention it because some people they take it as medicine. I feel mention it because some people they take it as medicine. So that thing for body they call it insulin. Now the substance you say our blood will make sugar no high. I ever to say insulin they like gate man. And then sugar they like picking when you come on or people they work out for street visitor.
They come back for us late.
If you come, now gate man there for open gate when you enter, go inside house. If you can't, gate man not there or gate man not tire, gate man not be open. So people that can't stand for outside. And if people that stand for outside, they go block road. And if they block road, trouble will start. Just imagine motor one pass, crowd don't can increase outside, they dinner like 30 people because they not going enter house. So nothing insulin to do. When sugar come, insulin they open the door so that when sugar come off from blood enter inside cell. So when that belly big, it make a insulin tire. Insulin of it do it work again as if it do I'm fine. So that time sugar they start remain for outside instead of enter inside cell. And that outside on the blood. And when it is high inside blood, it cause trouble.
And then now you make and you the weak too because the sugar need for enter inside a cell for you for get power. When it
Exactly.
plenty for your blood, but you no get power. You want test your blood, you see sugar and so high. They don't say that not that sugar they give you power and you get plenty sugar, but why your skin be weak? Now because they only there for blood, they not enter inside your cell way now for the way it go turn into energy.
It's just like say on a day for married for party for married, chop there for outside, but they don't lock door. On a day inside hall, on a non chop, on a stand die hungry. You will chop there for outside, get man on say no man will enter. Now I can't see. So we have to be careful when you see that kind of belly. Start to take care, say you start increase your the way you shake and the way you chop. So start to
So
work on
simple lifestyle changes could be used to modification could be used to prevent diabetes. And I think maybe doctor not talk because I not asking, but also they get stage three they call them to say pre-diabetes way when they measure your sugar a day between the normal one and that one we call and say diabetes. If when that sugar day for that level they call and say pre-diabetes way. If the next question what they ask you, we go what they ask you, we go answer them. If you change your lifestyle early, you start doing things like exercise, what I show say go talk, if it bring you back to normal and then you know go get diabetes. But if you know change your style, if you already shit on up a cell phone, the whole woke up for morning time, cross them, you press this thing. Like now, yes, Okada that even carry chop from a restaurant can give them for house. You press cell phone, proof, they bring you chop. You fit chop that chop so the 1 year again, say 3 years after. The fine boy will be there for every we get money, so the only come out go bar now you don't get diabetes. So yeah. So doctor, which kind of thing them way people they fit do for prevent me they no get this diabetes plan say type 2. I know say we not talk about type 1 today, but if you get second maybe after I will talk about so what kind of things could people do, especially those in the obese state, in the pre-diabetic stage, or even normal ones too, to prevent them from getting to the stage of diabetes. And I sure say you go mention and to say that obesity way we talk to that time if it cause too high blood and even heart attack. I sure say you go talk about that one after.
Yes. So I mean I think we don't talk plenty, but we'll say a little bit because they say the mommy for teaching na repetition. So if you never yet to get diabetes, and even when you don't get diabetes, now your prevention lie now for two major ways for we go change them for your life. When we move big English say lifestyle modification. So the same thing I say change not should I get a couch. Or the simply say no should I get a couch, not the overtake Okada, not the over all that in the way they make you need to be active. And then at the other here sometimes when I talk, some mommy will tell me say, "Be my picking, I go farm every day now. How the team money can catch me, you know?" So you get to increase from your baseline. You get your natural listing where you did it, but you get to increase that exercise. You get to shake that body. You get to shake that body. So if you really should on for couch, watch TV, as my brother talk, you press your phone. You press your phone. Now we now will be the screen generation. All man gets screen with phone.
Android.
From begin to papa. You get to start. You get to change from that. I get some boss because when next time you take taxi can drop you. Because in 1 ton go, in 1 ton. So I beg I feel leave you for you because I want to go drop someone with instead of vex taxi. I don't like the on a team on a taxi man I ever do. And I like the thing so I will give my destination. You will carry me there. You can't drop me for you. Tell me say you have to go drop me for front. No, next time when it happens, so no vex. You can consider and say that 10 minutes we go work. It will help you for your diabetes for prevent diabetes. For example, if you also say for morning time, you know, say you go walk, if you come out 10 minutes earlier, you use that 10 minutes, you walk for your usual spot where you go take taxi. Walk again 10 more minutes, go take taxi for fun. That's small way, then that way if you add them for the way to do. If you work at 10 extra minutes of morning, go take taxi for fun. And when you come off work, you drop again. You instead of take taxi, say at the I don't know which junction I will call them. Obili. If any man know Obili, instead of stop for Carrefour Obili, you just say you stop for
Machine Melen.
You stop for machine and you work at the rest camp. All that small thing, and you see and say they change, they could completely change. That are just small thing that you obviously if you feel do more and will be encouraged to do more, then do more. That are one aspect. So include physical exercise. Usually the doctor say may you do at least 30 minutes per day. Now the new recommendation that do at least 30 minutes per day. But inside that 30 minutes per day, not do less than 3 times a week.
Mm-hmm.
Start at least from 3 times a week, 30 minutes per day. Work as with fear your heart the beat faster. Now so you know so you don't do exercise. When you don't do it, you feel your heart the beat faster. That time you don't say yes, you don't put some effort. Now that one way. Another way now will change the way you chop. Inside your pan, you can forget more green, more brown, and less white. White na all thing way na as we call them carbohydrate. Cassava, rice, bobolo, cocoyams, plantain. Some people when they chop plantain over ripe, they diffuse it on a sugar. I just clear now. I clear any man in doubt. Plantain na sugar. Now either when it ripe, it is sweet. I know some people they ever say no, but chop na plantain no, you don't ripe. Na sugar. Some people they say, oh, when I drink honey, not be honey fine or honey na sugar. So you therefore consider all that thing you therefore reduce them. I know the talk say me you not chop on it. It's if you do what that state will be called as pre-diabetes, like before you want to enter full diabetes. That stage where if you reverse, go back to normal state. If you reverse that motor, go back to normal state. If you do that state, start to reduce that kind of thing. Begin to chop more of green, chop more of thank God to come up with some with plenty vegetables. Include them to your chop. May a pan. If you look your pan, divide it into two, may half being a vegetable. But as we talk again, not go cook that vegetable with plenty oil. Because if you cook that vegetable with plenty oil, you will cancel the good effects where you where you won't get them by eating the vegetable. So in a nutshell, we're not really go into details of how diet will be. There's no saying that the true pillar in that we have work on. No, she don't want place again. No, she don't want place again. And then change the weight. Plus, in addition to that, go to do your test. Maybe go check your blood sugar. If you don't reach 40,
especially 40 for both man, picking and woman, the recommendation I see as we reach 40, you go do test. They call that test and say screening. There is screening. And then I think say they talk against whether not every 3 years or not every 5 years old. And then another thing where doctor not talk again will be very important, especially for women. They will deal with belly. They get their own way that they call and say gestational diabetes mellitus. When a diabetes it start you now only time when you be pregnant. And you want the risk now say if they no treat and quick, if no control and that time you did belly, they no screen and they no test, they no do them. You are picking can be big now. Why that way you hear some woman them especially one born they picking over big, they cut in a cutty. And they begin to can get diabetes in future. The mommy too can get diabetes too after we run born. So all that one and the take home message today and say do your screening test, especially for pregnant women and all adults greater than 40 years. And then exercise is very fundamental, or lifestyle modification. And also, like you mentioned, it is also very important to control your diet and the kind of things you eat, decrease the amount of carbohydrates you did. Now, why that I see, especially on Facebook these days, I see a lot of people talking about on diet, and I encourage some of those who run videos on modification of diet modification and control of diabetes, specifically type 2 diabetes. And Krista and Jim, I don't know if you guys have anything to add. I know I've excluded you in this session, but that was I intended to do so. So my apologies.
No, I think doctor has already said everything, but I think the other thing where it is for talk that for reduce the amount of national volume where you take.
Yeah, alcohol, yeah, beer, plenty beer. Yeah, I think we need to also highlight that because that is one of the most common cause of obesity. And also another thing that alcohol can cause, and Arnold and I had this discussion the other day, acute pancreatitis. So the year sometimes say, boy, don't drink me for night. He go ask belly hot, boom. Before they want to take it go hospital, he don't die. They talk to poison and a poisoner. Win a different thing. So that is also very, very important. Alcohol is definitely not a good thing. No one is telling you to stop drinking alcohol, but moderate it. And if you drink, don't drive. A lot of accidents also, another common cause of death in Cameroon, which we didn't mention. And it's not a problem of the healthcare sector, like Arnold mentioned. Sometimes some of these problems are not a problem of the healthcare sector, like no water is controlled by the Ministry of Water. But then that will trickle down to the healthcare system. No electricity. It's not a problem of the Ministry of Health or of Healthcare. But then, if there is no electricity, then at times physicians working in the ward or in the who have to perform surgery will not be able to do their job. So everything trickles down. So it's like someone asked, must it always be the government? Yes, it has. The government has to do its own part of it, and then the rest of it will trickle down to everyone else, both the patients, the individual communities, as well as the different actors, including those who sell drugs in the streets, as well as the consulting physician. Jim, do you have anything to add?
No, not actually. I think Arnold has really broken it down to very simple terms for everyone, and yeah, I don't have anything to add on that subject.
Yeah. So okay. So we have come to the end of our show today, and thank you very, very much for everyone who spend their time out there, all our audience, but most importantly to all our guests for all the time they spend to educate the public. I very much appreciate. I'm sure in the future, a lot of people have sent me messages about women's health disorders such as cancer. I hope I'll be able to bring you guys to chat a bit on that. Christabel had an appointment. She had to see a patient, so she left earlier. Hopefully in the future, I will bring her back as well. So thank you, everyone. And you guys just stay in the lobby when I stop, when I end the show, so that we can have one or two discussions. And shout out to Team Debate Cameroon. So that is Omar Baye, Ndip Ayotako, Funix, Mbolenane, as well as Tres Katos, as well as all our fans. We very much appreciate, and hopefully you can share this video to everyone there. The last section, I actually wanted Arnold to speak to our parents out there, some of the people out there. I know the show has been only in English, but I'm sure most Cameroonians understand Pidgin. So I thought as much to make sure this message goes to the consumer. It should express himself in the Pidgin language. So thank you so much, and we'll let you know when we're bringing our next show, which will be hopefully in the next 2 weeks' time. Thank you.
I have one very last thing to say. As an information, I think I just feel I have to give out. Although it's the Cameroon government we're talking about, but I don't know. I can just give it. It might help somebody. So I think 2 days ago, I was watching. My husband was watching CRTV, and this week, April 25th, is World Malaria Day, and the steps which the government is taking to kind of help us to prevent that. rampant epidemic we have is that they're giving free malaria treatment to all kids under the age of 5. All kids under the age of 5 go to the hospital. I guess maybe your district hospital, you get malaria treatment for free. And then pregnant women, you pay 50% of your healthcare costs. So I just thought I should put that out there. It might help somebody.
Okay, great. Yeah, that's true. It will definitely helps someone. And then another thing which has been of interest to most of you guys there on social media is mostly sickle cell disease. Sickle cell day is coming very soon, and I know some people are organizing some events in Cameroon in the month of June. So maybe I can bring some of you guys so that we chat a bit on that. So Arnold and Jim, if you guys have a last word before we leave, you could.
Yeah, I think I do have something to wrap up here, and I want to really mention the concept of One Health. The narrative of global health is now changing and trying to incorporate the idea of One Health. And the idea of One Health is coming back from what Arnold mentioned initially, that there are health problems that we face, for example, the rare disease, that are not emanating, that are coming from a different angle, like you said, water, lack of water, and so on. It's not provided by Ministry of Health, but the absence of that will cause a health problem. And nowadays, there's a lot of concern about zoonotic infections, right? Infections that are transmitted by animals to humans. So what it means is that if the Ministry of Livestock or the Ministry of Agriculture is not doing their own job, we have health problems, zoonotic infections coming within our hospitals. We have to deal with the avian influenza and other kind of zoonotic infections. So I just wanted to reiterate the whole concept of One Health. It is very important that the government adopt this One Health policy. It's kind of a multi-sectoral approach to improve public health outcomes. Well, there's that interaction or a partnership or working together between the Ministry of Health, the Ministry of Livestock, the Ministry of Agriculture, the Ministry of Town Planning, to work together in order to reduce or mitigate the burden of disease within the population. So that's kind of my last say here in terms of policy and how to go around the health problems and improving health outcomes in Cameroon.
Great. Thank you very much, Jim. I very much appreciate all your efforts to stay here above your time that indicated that you will be here. And Arnold, you have a last word?
Well, it was a pleasure being on this platform. I know I've discussed a lot of things. I'll still mention that a big fan and hoping that we can move to healthcare for all, as fast as possible. I know there's a lot of challenges, there's a lot of questions that are there, but I also think we just need to have some baseline questions answered. And when I mean answered, I mean put in place. What's clear is that you cannot have all of the answers when you start such an endeavor. But if you can have most of the foundational ones going, then it's to jump into water. So that's my hope and prayer for the country. Besides that, I glad to be here, and if ready at any time to contribute, towards topics that can directly impact, on the listener, because I know one aspect was, kind of theoretical, and then we had some also practical things that we have seen that people listening to us should have been able to pick out. And so I'm just happy. I also want to say thank you to the other co-members of the panel. That thank you for that we all brought together to enrich this session. Yeah. So I think that. Now we all for me. Yeah.
Yeah, we are really very delighted to have you, and hopefully you will come back soon. And Crystal, you have the last word.
I just want to thank the team for having me, and thank you to the contributors. Thank you for my husband. He helped put everything up for me, set everything up, and bring some of the medical information I have. Um, I Before I leave, I just want to say we really have to advocate. We're very behind, compared to other countries in the world when it concerns healthcare, and it starts with the politicians. So I don't know whether we should knock at the doors of our parliamentarians, senators, ministers.
We should.
They really have to care, because when I hear Dr. Christabel saying spending went down to about 3%, and that is really, really sad. Um, we have to make them care about us, because our healthcare is our life. So I don't know. Maybe we should ban them from traveling abroad whenever they get sick, and they will care so much about the healthcare system in Cameroon. So there's so much work to be done. Um, there's still hope. So we're hoping that it's going to get better as time goes on.
Okay, thank you so much, everyone. And this is the end of our show. I'm looking forward to having you guys next time on, especially to our audience on the Debate Cameroon platform. Goodbye, everyone, and see you next time. My name was Terence Agbo.
Wow.